syncope, neurocardiogenic syncope. Postural hypotension, also called orthostatic hypotension, drug-induced, especially antihypertensive vasodilator drugs. Peripheral neuropathy causing orthostatic hypotension like diabetic peripheral neuropathy, alcoholic neuropathy, or idiopathic postural hypotension. Sometimes there will be carotid sinus hypersensitivity which causes syncope. Anemia is a very common cause of syncope. Situational syncope like cough syncope, micturition syncope, Valsalva syncope are also described. There is another entity called glossopharyngeal neuralgia, and this is associated with syncopal attacks. The cardiovascular disorders that cause syncope include bradyarrhythmias like sinus bradycardia, sinoatrial block, sinus arrest, sixth sinus syndrome, atrioventricular blocks, decreased left ventricular ejection fraction of any reason. Tachyarrhythmias like supraventricular tachycardia, atrial flutter, atrial fibrillation, and ventricular tachycardia. Other cardiopulmonary causes like pulmonary embolism, pulmonary hypertension can produce syncope. Massive myocardial infarction is a common presentation of syncope. LV restriction or constriction due to restrictive diseases of the heart or constrictive pericarditis, hypertrophic obstructive cardiomyopathy, also these can produce syncope. Before diagnosing a patient to be having syncope, we have to differentiate other similar conditions like anxiety disorders, panic attacks, hyperventilation syndrome, brief spells of seizures, hypoglycemia, acute hemorrhage, hysterical faintings. All these mimic a syncopal attack. Internal hemorrhage, myocardial infarction, cardiac arrhythmias are emergencies. So it's important for us to examine carefully, and these emergencies have to be identified and they have to be treated vigorously and quickly so that the patient's life can be saved. Other forms of syncope are not life-threatening. This is an approach, algorithmic approach to a patient of syncope. If a patient is found to be having syncope, first of all we have to see about his history and physical examination. If the history and physical examination are normal, then it could be vasodepressor syncope and tilting test would be positive. If the physical findings are abnormal, then it could be cardiac disease or cardiogenic syncope. And we need to do an ECG, a rhythm strip, echocardiography, and electrical pathway mapping. If the syncope is due to orthostatic hypotension, we have to see what medications he is taking and avoid those which cause orthostatic hypotension. If there is a CNS abnormality, multiple sclerosis and other CNS disorders have to be considered. If there is a peripheral nervous system abnormality that is seen, then diabetic peripheral neuropathy, other causes of peripheral neuropathy have to be considered. This is how we can make a differential diagnosis of different cases of syncope. Treatment of syncope. The first aid measures, general measures, drug treatment. The first thing that we need to do is keep the patient supine, head to one side so that he doesn't choke and there is good flow of blood to the brain. Do not give anything by mouth. Do not make him drink anything. Sprinkle cold water if possible on the face to stimulate him to get up. Orthostatic hypotension, if it is suspected, then we have to make the patient raise up very slowly, step by step. The general measures include cause-specific treatment, avoiding postural hypotension, avoiding venous pooling, salt replenishing. Drug treatment, drugs like scopolamine, diisopyramide, carbamazepine, midodrine, antiarrhythmic agents, electrical pathway mapping, ablation of the abnormal pathways, and cardiac pacing may be effective in respective cases. Finally, after understanding vertigo and differential diagnosis of vertigo and treatment, and after understanding syncope and then the differential diagnosis of syncope, we are left with another entity called gait ataxia or unsteadiness while walking. Peripheral neuropathy of many causes can lead to gait ataxia. Myelopathy, cervical cord myopathy, cord compression, cervical spondylosis with or without vertebra-basilar insufficiency, spasticity due to motor paralysis, Parkinsonian rigidity, cerebellar ataxia, degenerative diseases of the cerebellum, arthritis and arthropathy of the lower limbs, degenerative diseases of the spine, poor vision. All these can produce gait ataxia or unsteadiness while walking. Carefully, the causes have to be analyzed and appropriate treatment has to be instituted.
Can you see anything in there at all?
Oh, black. And on the sides I can see little white.
I'd like you to turn now so that your feet are up on the table.
Better hold on to me.
I'm holding on, all right.
Yeah, because otherwise you're going to have someone going poop. Ooh, God, I'm getting dizzy. Okay. Now what?
I was going to have you lie down, but forward a little bit more because I want to make sure your head is on the table.
Me too.
Okay. Now let's slide back and try to do it. See if this just looks all like many eyes or something different. Eyes open.
Starting. Return back. walking. Oscillopsia, the illusion that the environment is moving when we move our heads, is the characteristic visual symptom when vestibular function is lost. Oscillopsia often occurs when riding in a car, especially when the road is bumpy. This can make reading street signs difficult unless the car slows or stops. Oscillopsia also occurs when running or walking quickly.
Ladies and gentlemen, I hope you had some good understanding about the various causes of vertigo, how to differentiate them, the central, the peripheral vertigo, the treatment, the BPPV, its commonest occurrence, the Hallpike maneuver, the Eplis maneuver, the exercises for BPPV, drug treatment of acute symptoms of vertigo, and of course the understanding of syncope, its differential diagnosis and treatment, and a little about the Gait Ataxia. And let us now thank you all very much for your patient listening. Thank you so much.